Thanks everyone for joining in on this talk. These are concepts that are really near and dear to my heart that I love to talk about. And so when someone asked me to do kind of a 40-minute talk on like concepts that I love talking about all the time, I was like, of course I would do it. I'm really excited to, and especially leading up to World Contraceptive Day, which is on September 26th. So I named my talk before I made my slides. And after I made my slides, I realized that actually the ordering of things wasn't entirely correct, but bear with me, it'll make sense in the end. I would also like to acknowledge that I live, learn, and work on the unceded territories of the Coast Salish peoples, keeping in mind that I'm a settler to these lands and I'm very lucky to be on these lands. Anyone who is on different territory, I'd urge you to learn more about the Indigenous peoples who were the caretakers of this land long before there was contact. So I'm Dr. Ruth Habte, and I'm here doing this presentation because I believe that contraception should be free. That's my own personal Twitter handle, but you can also find me at the AccessBC social media handles because I do part of that as well, and that's the AccessBC website. And just to start off with some disclosures, so I am a Black woman. I go by the pronouns she, her. I have lived experience as the daughter of immigrant and refugee parents. I'm originally from Winnipeg and I moved out here just over 2 years ago for residency. I'm an OBGYN resident physician and former pharmacist, so that informs a lot of the opinions that I've had as well. And I wanted to say I'm not an expert. I love these topics so much, but I'm truly not an expert. For experts, I would say, listen to Loretta Ross, look up Sister Strong, which is a women of color reproductive justice collective in the Southern United States. Read about Kimberly Crenshaw and her work on intersectionality. And if you want information on the research surrounding free contraception, I haven't actually done any of this research. I can appreciate it, but look at the work of Dr. Wendy Norman and Dr. Sarah Monroe, who are out of UBC and in the same department as myself, which I feel very lucky to even be associated with these wonderful people. And ultimately trust that people are the experts of their own bodies, and they ultimately know what the best mode of action is for themselves. So we're going to go over a couple of really big concepts today that in and of themselves could be like their own entire hour lecture. So we'll be doing a skate by of these kinds of things and what is the evidence for contraception being free, and then talk about the AccessBC campaign. So health equity is the first topic that we're going to talk about. If you had asked me back in medical school what health equity was, I would have told you this. And this is something that I actually wrote in medical school in 4th year. And this article was talking about global health. And for me, I felt that global health was synonymous with health equity. And that really meant that if a person was afforded less privilege in life, be it through SES, through their sex or gender, through the color of their skin or their religion, that they might need to be afforded greater means to be able to reach the same health outcomes as someone with more privilege. So someone who had higher SES, someone who was from a dominant maybe class that had more power in society. So that was my very kind of rudimentary thinking about this when I was a medical student. And I still think that this is correct. I think that I've built on this over time, pardon me. But if we look at what the WHO says about health equity, they say something kind of similar. They say the absence of unfair and avoidable differences in health among populations who could be defined maybe socially, economically, demographically, or geographically. So why then, when we talk about contraception is a targeted approach not enough. And this is Emily Weisenhall. She is a Med 3 out at the Kelowna UBC campus. She is part of the social media group who we plan this campaign. She's holding up a sign there that says free prescription contraception equals health equity, and I could not agree more. If we look at BC Fair Pharmacare as an example, if you think about the number of things that someone has to do to be able to even qualify for it and get medications covered, this person has to have MSP, first of all, has to have filed their taxes, has to apply for this program. And while they're waiting for the program to take effect, they have to pay out of pocket for whatever medications they're receiving. Their deductible is then set on their outcome, and they need to reach 70 to 75%, depending on the person or the family, before they start to get any coverage through BC Fair Pharmacare. And then after they reach a certain maximum, they get 100% coverage. And this is not on every medication. There's only certain medications and medical devices that are covered. So for example, I very recently looked into this, and one of the oral contraceptive pills that I prescribe, not uncommonly, called Lolo, was not covered under the plan. Nexplanon, the last time that I looked into it, was also not covered under Fair Pharmacare. And then teens are still listed under their parents' income. So these teens might be from a high SES household, but they themselves have no money to their name, want effective contraception, but if they tried to fill a prescription and get it through BC Fair Pharmacare, they wouldn't necessarily qualify. So in the end, the reason to advocate for free contraception for all is that people really shouldn't have to pass a set means test or have to justify through special approval their choice of contraceptive to the government to be able to access reproductive health care. So really anyone with a uterus should be eligible for a policy like this. Now, if we talk about reproductive justice, this is a much bigger concept, and I've attended, I don't know how many talks on this. There's long books about it as well. So these are really just distilled down concepts. The first thing I think is important to understand when we talk about reproductive justice is talking about intersectionality, and the fact that Kimberly Crenshaw, all the way back in 1989, so over 30 years ago, she's a Harvard educated lawyer. And this was the first time that she kind of published on it back in 1989. And here's a quote from that paper. So the way that it started was essentially Kimberly Crenshaw brought up a number of cases that had happened in law or class action lawsuits that weren't certified because the plaintiffs were Black women, and they couldn't prove that either there was racism and sexism involved. And what they had difficulty showing was there was one specific case where it was in relation to auto workers, and the company had employed white women at the front of this auto worker shop and Black men in the back working on the cars and what have you. But nowhere in this company was Black women employed. And when they went to court and tried to say, like, listen, there is racism and sexism happening, and our experience as Black women is not at all related to what the experience of white women have been or what the experience of Black men have been, they lost their case. And so this is something that Ms. Crenshaw was able to kind of depict in a really eloquent way of how the experience of Black women in the United States around that time was very unique. And it was greater than the sum of racism and sexism combined. So that's how it started. But she just recently gave an interview about this, and now it's used more as an all-encompassing lens to say, there are various forms of inequality, and the way that they operate together, they're not simply additive, but they actually exacerbate each other. So if you think about someone who maybe is a member of the LGBTQ community, who is a person of color, who is from a low SES community, well, their experience will be different than maybe someone with out of the three of those kind of factors about themselves. And it's really moved on to be this more all-encompassing topic now. And why I think that it's important for us to remember that is really the start of reproductive justice was in June of 1994, where this Women of African Descent for Reproductive Justice in the United States, in response to the Clinton administration proposing a Health Securities Act, this group of African women felt that their needs as a community were not being addressed. They felt that issues of reproduction that disproportionately harmed Black women, like poverty, like intimate partner violence, infant mortality and morbidity, environmental issues that they were raising their children in, as well as HIV. They felt that the reproductive rights movement, which happened to be led by middle-class white women, did not represent their needs and did not represent the intersectionality of what it was to be Black and a woman in America at that time, and even still to this day, these things are quite separate. So they bought full-page ads in the Washington Post and Roll Call. There was over 800 signatures calling for a healthcare reform package to include the concerns that Black women had about protection from discrimination, about helping them have access to healthcare services that matter to them, and being comprehensive with infertility services provided, STI screening, HIV treatment as well. So the framework then is really a combination of reproductive rights, as they understand that those are important. Legally, it is important to have the right to do things with your own body, but also be able to have access and have a community that's structured around social justice that allows you to live the best life that you possibly can. And so shortly after that 1994 kind of meeting, there was 16 organizations that came together to create Sister Strong. And Sister Strong is still a group that's going to this day. It's a collective that's devoted to the reproductive and sexual health of women and gender nonconforming people of color, and they're based in Atlanta. And this is the current executive director. She has a number of really amazing talks. I just took a snippet of a screenshot of a very short, succinct talk she gave on what reproductive justice, meant to her. And so what she says is, overall, reproductive justice is about the human right to self-determine. And I think that is very powerful and a very succinct way of talking about the concept. Loretta Ross, who is a scholar on this topic, has written books on the topic as well. At some point was involved as well in the Sister Song organization. So these are great things to look into afterwards if you're interested in these topics. And the important thing to remember, as we were kind of talking about, reproductive rights, yes, they're important, but reproductive justice is a different way of thinking of things. So the history, if you will, of both of these things were slightly different. The reproductive justice approach is more intersectional, like we were talking about the work of Kimberly Crenshaw. They really focus on the freedom to control your own body and also include parenting, which is not something that reproductive rights necessarily talks about. And it's a social justice focused field. And they really, really depend on the collective. They want communities to be healthy and communities to be able to raise children as they see fit. I thought this was an amazing quote to kind of bring this topic together. So this is Jessica Gonzalez Rojas. She's the former executive director of a large reproductive justice organization in the United States representing Latina women. And she's now actually a member of the New York State Assembly. So she says that reproductive justice recognizes the legal rights do not always translate to meaningful access. It centers the experience of the marginalized. immigrants, people of color, queer and trans folks, youth, and low-income communities. And the other thing that reproductive justice, includes is the right to parent. So a tenet of this is being able to parent your children if you want children in a safe environment, and to be able to have as many children as you want if you want them, and to also not have children if you don't want them. So it tackles the issue of forced sterilization. It ensures that the child should be raised in a healthy environment, and that women and people with a uterus really be supported in parenting, and being able to parent their child without fear that the child will be hurt or killed is a form of reproductive justice in and of itself. So while this framework was used to describe the experience of mostly Black women in the United States, I think we can take a lot of this towards Indigenous folks in Canada who, as recently as 2018, there have been allegations of forced sterilization. Children from Indigenous families have been stolen from their homes in relation to residential schools, and even to this day in the foster care system. So this is a framework that would actually be used to describe this as well. Now, I just wanted to go into a couple of case examples. The first case example I wanted to talk about, because it's very recently in the news, is the Texas abortion laws. So I'm sure most people on this call have heard about, but as of September 1st, Texas implemented a new, very restrictive abortion law where it really limits the ability for people to get any type of abortion care in Texas after about 6 weeks, and then sometimes kind of earlier. So it's basically as soon as there's a heartbeat, it becomes very difficult for this person to receive care in Texas. And so note how this is very focused on the law. This is a concept of reproductive rights. But if we look at what Texas was like before, if we look at what the climate in Texas was before for abortion and for contraceptive access, well, they had a lot of restrictions on minors being able to access abortion to begin with, and to be able to access contraception without telling their parents. The pro-birth movement has very much been emboldened. They are protesting outside of clinics, making people feel uncomfortable, like they can't access the clinic. There were very few abortion centers to begin with, and there were very, very few that were available to people who were in rural locations, or people who were low SES and maybe couldn't pay for certain procedures if they were farther along. And then overall, social supports for people, if they wanted to parent or wanted to have access to contraception, was really minimal, or it was lacking altogether. So I was able to find a reproductive justice organization in North Texas, and they say they're the only one that was in North Texas. And the reason that they were founded is similar to talk about the disproportionate rates of HIV amongst Black women in North Texas. And they now have lots of different programs listed on their website, things about HIV, things about abortion access, and as well things about maternal mortality. So that's Texas kind of in a nutshell of how, really, to begin with, I'd say from a reproductive justice perspective, there were groups that were really doing some on the ground work, but the more recent change in their legislation represents a change in the rights of women rather than the change necessarily just in access, as that was an issue before. I think it's also important to talk about reproductive justice as it relates to contraception. So, if we think about, again, the issue of reproductive rights and what is available legally to people, it is never, contraception has never been legally available, to my understanding, for everyone in British Columbia at no cost. And even from an access point of view, it's still difficult to access contraceptive care in rural, northern, and Indigenous communities, depending on what type of physician or nurse practitioner coverage they have, what the comfort level of these providers are. Are they able to provide the implant? Are they able to provide the IUD? Are they willing to do these things as well, because that comes into play as well a lot of times in rural centers. And so I think we need to remember about this concept as well as we move forward. That's more than simply putting into place a law to say that it's covered by MSP, but actually making sure that everyone who wants access to it is able to get access to it. So let's talk about the case for free contraception. Most of the dots on this map are in Europe, and these are a couple of the countries that already subsidize universal access to contraception, either in full or in part. It's definitely not an exhaustive list. This includes the UK, France, Spain, Sweden, Denmark, and the Netherlands, as well as, pardon me, Luxembourg, Italy, Germany, and Ireland. So cost overall impacts the contraceptive options that a person would have access to, and it remains a critical barrier to this day. And the problem, as I was kind of alluding to earlier, was really there are multiple barriers to being able, to access reliable contraception. And these are, the cost issue is really exacerbated by someone maybe being a new immigrant or being a new refugee. They don't have a good handle on how the healthcare system works and how to navigate it. Someone who might be from a low SES background and does not have the capability of paying for this out of pocket while maybe they're trying to navigate the fair pharmacare procedures. Someone who's a young person, so this person might be a teen and maybe they have drug coverage through their parents, but if they fill the prescription through their parents, well, their parents will figure out what's going on, and they may not necessarily be at a place where they're comfortable sharing that kind of information with their parents. And then again, if someone's from a small rural northern and or indigenous community, it may be difficult to even have access to healthcare providers who are skilled and able to provide contraceptive care. So if you haven't already, the Contraceptive and Abortion Research Team at UBC is a place to check out in terms of research in this topic. And so there's lots of research that has come out of here. I've just taken a couple of ones that I wanted to highlight. So overall, Canadians tend to use less effective forms of birth control, and the lower SES groups even more so are likely to use injectable contraceptives, so the Depo-Provera, or condoms alone. And that's important to keep in mind, because a lot of the times, like, these are quite cost effective. The injectable contraceptive, it lasts for 3 months. People pay about $50 for that 3-month period. And it's more cost effective for someone who maybe doesn't have the money to put towards an option like an Implanon, which is quite expensive upfront, or a Mirena IUD. And so let's go over some of the data that's really in support of universal contraception. So this was the choice study out of Washington University in St. Louis, Missouri. About 1,400 teens from the years 2008 to 2013. All of these people received standard contraceptive counseling. And then at the end, were given the option of their choice at no cost. And 72% of these people ended up choosing the long-acting contraceptive method. So this was either an IUD or an implant, whereas 28% of people chose to go with birth control pills, patches, other things like that. And what they found is, in the people who were involved in the study, compared to all teens in the US, the teen pregnancy rate was drastically reduced, the teen birth rate was reduced, and the teen abortion rate as well were reduced. And a Finnish study showed something very similar. So they found that when they provided free of charge contraception and also provided no age limit on the access to emergency contraceptive, so this is things like the morning after pill, or Ella in Canada is another version that's slightly more effective, or potentially even a copper IUD, that these overall were associated with lower pregnancy and lower, teen pregnancy and lower teen abortion rates. And it was quite significant as well. One of the biggest studies in this area is the Colorado Family Planning Initiative. And so this was a $28 million grant that provided just over 43,000 IUDs at no cost to the patient. And they have a big, long report about it and have had several studies kind of afterward reanalyzing the data and looking at the outcomes of this study. But in a nutshell, they found very similar things. So reduce adolescent birth rate, reduce teen pregnancy rate by 54%, reducing teen abortions by 64%, and saving over $70 million in public assistance costs. Because ultimately, if certain teens get pregnant, a lot of the times they are dependent on some public form of assistance to be able to, first of all, birth their baby, especially in the United States, where Medicare is a thing for people who are lower income, and then as well depend on them maybe afterwards to help them get on their feet. There was a study that came out after the initial study was released that looked at high school diploma rates in women who were part of this study. And they found that there was a significant increase in the amount of people who are able to finish high school if they were a part of the Colorado Family Planning Initiative. So if you think of high school as kind of their entry point into either higher education or to higher paying jobs, this can really have an impact on this person and the rest of their life if they're able to have access to this effective contraception. So I wanted to bring up this quote because I've read through this Colorado Family Planning Initiative, and there was lots of quotes that were featured, but I really liked this one. It says, "Do you realize how much money is being saved in welfare alone by preventing early and unwanted pregnancies? It boggles my mind." I mean, me too. The data out of Canada would tell us that there's about 187,000 unintended pregnancies in Canada every year. We're a public healthcare system, so this costs us $320 million per year in direct costs. And a lot of this cost is from imperfect contraceptive use. And if we had people who, let's say, wanted to have access to a long-acting form of contraception, but weren't able to, maybe because of cost or because of access, we could save $34 million if we were able to have increased access to long-acting reversible contraceptives like the Implanon or the IUD in Canada. And just to further support this point, so if we look specifically at Canadian adolescents, there's also separate data showing that there's over 39,000 unintended pregnancies every year in this cohort with a direct cost of over $60 million. And 2/3 almost of the cost is from being unable to follow a contraceptive regimen. And they found in kind of cost modeling studies as well that increasing the long-acting reversible contraceptive uptake can save up to over $3 million. The Options for Sexual Health 2010 report was very well done, and they are specific to a BC context. So while the data was from just over 10 years ago, it's the best that we kind of have for what is published and available to the public to look at. So they found that for every dollar that was spent on contraceptives, that the government can save as much as $90. And overall, the BC government could save as much as $95 million annually. Now, of course, there would be some upfront costs to putting in place this type of plan. It would cost about 60 million or so, 50 to 60 million is what the estimates are, but overall still a cost saving mechanism. Okay, so now that we've gone through all of the data, I wanted to talk about AccessBC and the organization that I am a campaign organizer for. So roots are back in 2017, January. So Dr. Teal Phelps-Bondaroff, who is the person in the hat with the circle glasses just right at the front, and then Devin Black, so the person with blonde hair and glasses, started the campaign back in January of 2017. And these are some kind of early photos of some of the other people on the campaign as well. And the goal was really to make all prescription contraception free in British Columbia. So well prior to me joining the campaign members conducted research, they made a briefing paper, they met with several MLAs as well as ministerial staff, they've done outreach, consulted with government, and here's a couple of members who were doing some outreach back in the early days of AccessBC, when of course we weren't wearing masks and stuff indoors. So for the time that was considered normal. And all of these things were done with the goal of making prescription contraception in BC free. And as you can see there, they have the sign that says, birth control is a human right. So the letter writing campaign, rather, is a tenet of the campaign. So I can't share too many details, but essentially thousands of folks have written letters and tens of thousands of letters have been sent to MLAs. Here's Teal on the right, and Erica, one of the other campaign folks on the left, holding some paper letters, I think probably back when they were doing paper copies of things. We've now moved to an online platform, an online letter writing campaign, and I actually wanted to take a brief moment to have anyone who's from BC in the audience. It's very easy. I'm going to do it with you guys to log on to accessbc.org/the campaign. So I'm going to log on with you guys, accessbc.org/the campaign. So you're going to get a page that kind of looks like this on your phone, just making sure that you can see this on your phone. Oh no, my thing is, I'm just going to remove my virtual background so that you're able to see this. And so you can kind of see that's what it looks like. So we're going to go through and fill that out. Go back to my regular background. Okay. Sorry, guys. Okay, so I'm going to go back to here and we're going to fill out this letter. So this is, even if you've done it before, as long as you haven't done it in the last 2 weeks, it's very easy. You just put in your first name. So I'm going to do it too. You're going to put in your last name, put in your email address, and then put in your postal code so we can track who is doing these letters. Let me put in my postal code there. And I've sent in a letter already. So I'll say, dear recipient name, will go here. I am currently giving a presentation on the topic, and we are all wondering when contraception will be free in British Columbia. So as easy as that, the letter is sent and then you'll get a confirmation screen. So we have tons of pins to give away. So if anyone is hopefully doing it right now as we speak, take a screenshot of the end products. You can't really see it super well there. You can kind of see it there to say that you've sent it. Send a screenshot to the AccessBC World Contraceptive Day email, and the first 3 people to do so, I'm happy to send, myself and Teal will be happy to send you some buttons for you and your friends as well. And let's talk about the campaign that we have going on right now, pardon me. So this is the World Contraceptive Day 2021 campaign. And as mentioned earlier, September 26th is World Contraceptive Day this year. We kind of borrowed the idea from the sister campaign in Ontario, Cover Contraception, who healthcare providers essentially took a photo and explained why free contraception is important to them. So to have people either post on their personal social media pages, which hopefully would be public so that we can amplify the message. Or if, let's say, your social media wasn't public, but you were okay with us sharing the photo, send a copy of the photo to accessbc.wcd@gmail.com. And I personally moderate this email along with other people from our social media team. And some bonus points if you include like pets or kids or something that's really, cute to look at as well. Here are a couple of ones that I wanted to showcase. So this person on the left says, I'm a physician and I support free prescription contraception because it is the right thing to do. And on the right-hand side, funny enough, I was on call yesterday and met this person in the flesh. I am a family doctor. Her name is Kathy Wang. And she's a lovely person and she supports free prescription contraception because pregnancy should be a choice. So we would be more than happy for anyone who would like to join the movement. So either sending a letter in support to MLAs like we just kind of showed you how to do. We're also doing this targeted approach where we have about 2 weeks of sending focus letters to a couple of MLAs and then change it every 2 weeks. So doing one today, which is the latter half of that 2-week period, and doing one again next week would be very helpful in moving this campaign along and making sure that it's still forefront on the MLA's minds. Joining in the hashtag WCD 2021 campaign by using that hashtag and hashtag AccessBC so we can find your post and amplify it and make sure that it's sent to the correct government officials. That would be awesome if you're supportive of this campaign and able to do those two things. And just before we wrap up, I'd love to acknowledge some people who have been very impactful on my journey for this. So Dr. Helen Pymar is an OBGYN in Winnipeg, where I did medical school. She is an amazing advocate for people. She is a person who really got me interested in family planning and an amazing physician and an amazing advocate for reproductive health care in Manitoba and throughout Canada. Dr. Teal Phelps-Bondaroff, who is the current chair and a co-founder of AccessBC. He's reviewed these slides for me. We go back and forth on so many different things, bouncing off ideas off of each other. So thank you so much, Teal, for being really patient with me. He's much more in tune with political organization than I am. I'm just kind of a free spirit who has energy and who has passion to give. Devin Black, who's no longer a part of this campaign, but is a co-founder and was an amazing resource and gave me amazing handover before she had to leave. Kennedy, who is a campaign coordinator, who is fantastic, runs the email list, is very responsive and lovely to work with. And then the next three people, Emily Weisenhall, Marissa Lebec, and Dr. Sarah Mallison. The four of us kind of form the informal social media crew of AccessBC, and we've all worked very hard to put together an Instagram page, do the Twitter and socials, and update our pages regularly. Okay, and that is all I have to talk about directly. And if anyone has any questions, I will get to the chat.